All right, let's do some spinal anatomy. It is Wednesday. It is week 8. Here we go. Holes. This is kind of a review. We talked about most of this stuff. So this looks like a lot of slides, but we've done a lot of this already. Remember, there's 2 holes in the cervical spine that serve as protective purposes, for protective purposes. The vertebral foramen and the neuroforamen. Vertebral foramen, of course, is there. You put 2 of these together, you have yourself a vertebral canal. A bad AKA for this, if you have 2 or more of these together, is central canal, because remember, was it yesterday? Or I forget if we've done this or not. But there's a central canal in the middle of the spinal cord. I think I showed some of you yesterday in lab. So you shouldn't call this the central canal. You should call this the vertebral canal. Or if it's just one bone, the vertebral foramen. Right, and here's a mid-sagittal CT slice. Right, we can see our dens now, right? We're pretty good at knowing the dens. There's the anterior arch. We're going to talk about this today. I don't think we talked about the ADI space, but there's a vertebral canal. The neuroforamen, we've talked about that yesterday, but just for a review, there it is. Now we don't have a perfect, this is a A to P view, but we can see it. Perfect view is if I move the camera over to 45 degrees. I think, do I have a picture of that? There we go. There's a 45 degree angle of it. And we can clearly see what makes the borders of it now. This is the uncinate process. The question could just say the vertebral body, because the uncinate process is part of the vertebral body. So you have to just kind of use common sense or use your knowledge to answer the question. The vertebral body up here, it's really vertebral body is here, uncinate process is here, superior vertebral notch, and then this whole back thing you could just call the articular pillar, right, of both members of the motion segment. Or maybe they'll split it apart and say the superior articular process forms this part. Here's inferior articular process, and really we're at the right here is the pars interarticularis. That's why pars fractures, sometimes when they heal, they grow a little pointy thing called the beak. And the beak stabs the nerve that comes out. Okay, and then the inferior part would be the inferior vertebral notch. Right, so that is all the stuff that forms the border. You definitely want to know that. What does it do? It transmits. That means it allows for the passage of the spinal nerve root, dorsal root ganglia, spinal nerve. This is all variable. It depends where the dorsal root ganglia. It's usually located in the intervertebral foramen. Some people, maybe it's out here, outside of the intervertebral foramen. So it can be variable. There are some, did I show you that? Let's see. There are some arteries. There's a radicular artery and vein that also transmit through there. How do you name the hole? And I don't think we went over this too much. So the hole can be named in 2 ways. It can be named by the members of the motion segment that form it. Let's go back and look at this. So if this is C5 and this is C6, you could call this the C5/6 IVF or neuroforamen or intervertebral foramen. Let's just use AK. We'll just use IVF for now. Another way you could name it, and the way most medical doctors or spine or pain management doctors, injection specialists, they would just call this C5 IVF or C5 neuroforamen. It's exactly the same naming system as the disc, because you could call this the C5/6 intervertebral disc or just the C5 disc. Right. Right, exiting nerve roots. How about the exiting nerve roots that come out of here? Let's go back to here and look again. Let's draw an exiting nerve root. So I think we know this already, but this exiting nerve root and all its pieces are named by the bottom member of the motion segment. Right, so it comes right out this little, there's a little gutter for it, kind of the gutter for the exiting root. So this would be the C6 exiting root. This would be the, remember this C6 medial or dorsal ramus. This would be the C6 ventral ramus. We did this a lot yesterday. The spinal nerve would be C6 spinal nerve. This could break into a medial branch that supplies the facet joints, and a lateral branch that goes up and supplies some of the erector spinae muscles. The medial branch actually has another branch that goes up and supplies the multifidi muscles. Longissimus thoracis is supplied by this lateral branch, and sometimes there's an intermediate branch, sometimes there's not. And that could maybe iliocostalis lumborum. You'll learn the muscles next quarter, but bottom line is this is all C6 property. Got it? It's named after the bottom member of the motion segment. All right. There's just another example. So what nerve root would this be? Quick. Well, look at the motion segment, the C5-6 motion segment. It must be the C6. And it is. This is all C6 property. All right. There's just an example. We haven't really seen the inferior vertebral notch. But there's a picture where we can kind of push the transverse out of the way. And so it's right there, and there's this where the nerve would be there. Right, there's another view of it. Right, so if this is a C6, this is all C6 property. C6 dorsal ramus, C6 ventral ramus. We could have split this medial branch, lateral branch, maybe an intermediate branch as well. What else do I want to say? Remember, this would be the C5 disc right here. Right? Remember, the bone that sits on top of the disc conquers it. Look at a very deep vertebral notch here. All right, let's do a little, okay, here comes the neuroanatomy. Just some very basics. I mean, you're going to have plenty of classes in this. But the central nervous, remember the body, it has basically a central nervous system, a peripheral nervous system, and an autonomic nervous system. The central nervous system is made up of basically the brain and the spinal cord. There's the brain, there's the spinal cord. We know the spinal cord travels through the vertebral canal, and it also leaves through the neuroforamen. What does it do? It sends messages out to the body through the motor nerves, which we looked at in lab yesterday, and it receives messages in from the sensory nerves. Right? And we won't worry about the autonomic system for right now, but that's just the very basics of this. The spinal cord has segments. I showed you the segments. Remember, the segments are defined by the nerve rootlets. They will show you where the segment is. You should definitely know this number. There's 31 segments of the spinal cord, or 31 cord levels. It's kind of an AK for segments. Specifically, there's 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. And forgot the T there. Nerve rootlets would be right there. And notice that the spinal cord, we already know this, it stops at about the level of the L1 disc as the conus medullaris. So where's the coccygeal spinal cord level? Well, it's right at the very tip of the conus medullaris, so it's down at about the T1 disc. It's about this level. Okay, because we went over that concept before. The levels of the spinal cord don't match the holes, the neuroforamen, where these nerve roots leave. Up here, they're pretty close. Remember the model we looked at C5 yesterday, how the spinal cord level is pretty much adjacent to the neuroforamen that allows the nerve to go out. Okay, everything I just said. Remember, the sensory and the motor nerves come together to form a short-lived spinal nerve. Here's the board question. It's a mixed nerve because it's got sensory fiber in there When I say fiber, I'm just talking about the long nerve roots and the axons that go with that, kind of a general term. It's got motor nerves and sensory nerves and sympathetic, parasympathetic, in some cases, mixed in with it. So it is a mixed nerve. Spinal cord lives within a dural sac or thecal sac. The outside, of course, is made of dura and arachnoid. We looked at that yesterday specifically. And we know that do I have a picture? Yes. So the thecal sac, I don't have a picture of that yet. I'll get to it. But the thecal sac, the nerve roots exit the thecal sac by pushing out, and they take the dura mater and arachnoid with them. And we know the cerebral spinal fluid is also inside the thecal sac. So the dorsal root ganglia is surrounded by cerebral spinal fluid. It's almost over that little interthecal region. Right after the dorsal root ganglion, it stops. And then the dura and arachnoid morph into the regular, like epineurium and perineurium and endoneurium, those regular layers of the nervous tissue, which you'll study probably starting next quarter. Right, so here's this picture we looked at kind of yesterday, but you can see the concept of a level. So what makes up a spinal cord level is the area where all the rootlets go into the substance of the cord. So this would be the C5 level from here to here. And yesterday we said that the anterior-most nerve rootlets, those are motor, so the signals are going that way. These signals are going that way. Those are incoming sensory. And we said we go from nerve rootlets. The nerve rootlets converge to form a nerve root. That could be called the motor nerve root. And then they morph together right here to form a spinal nerve, which is a mixed nerve. It's got signals going both ways. It's made of sensory and motor, as well as autonomic. We have a dorsal root ganglia where the cell bodies live. They look like little octopuses. What does that be? Octopi. Very sensitive structure. And you'll learn more about that when you get in neuroanatomy and neuroscience. Right. The other concept here, just imagine this is all filled up with cerebrospinal fluid. See how the cerebrospinal fluid would go all the way out right to here, and that's the end of the cerebrospinal fluid. No cerebrospinal fluid. Spinal nerve is not surrounded by cerebrospinal fluid, but the dorsal root ganglia and the motor root is still surrounded by cerebrospinal fluid. Okay, just a blow up of that concept. There's a real overhead view. I think we're going to look at this more next week in lab. But this is a set or axial cut right through the C5 vertebrae. We don't see a disc here. It's actually, did they scrape the disc off? Because I don't really see the pedicles here. So it's very close to a disc level cut. Nevertheless, here's what we looked at yesterday. Here's the spinal cord, right? Very delicate structure. It's got that little H of gray matter in there. Central canal you can't see, but there's a hole right there for central canal. White matter on the outside made of myelinated tracts. And then we have our nerve roots. Can't really see the nerve rootlets very good. They kind of have a little membrane around them. But they are there. If you dissected this out, you could see them. But this whole thing is if you can't see the nerve rootlets, you just call it a root. So that's the C6 dorsal root, C6 ventral root, if you will. Or you could call it the C6 sensory root, and C6 motor root would be right there. Dorsal root ganglia you can't really see. Okay, we went over all those layers in lab yesterday. Note though, this is the facet joint, right? That's what you're going to be adjusting right there. Those are the Z joints. This is the lamina. The dura and arachnoid would be together here. The thecal sac would be here. This would be intrathecal, this region, because there's the arachnoids kind of peeled back. The dura would be on the other side of that. Ligamentum flavum would be right there. And then you can see bone right there. There's the lamina. And there's that. Can't see in this one the epidural venous plexus. You can't really visualize that well. Right, so here's the model we saw yesterday. Make sure you can name all these structures. So these are fair game for lecture and for lab. I already did this in lab, so I'm not going to go over this again. But you can watch the lab video. I think it did come out. If it didn't, somebody email me and I will send it out. They don't have the tubercles on here. Very good. And the vertebral artery, vertebral veins. And I'm not going to go over this. You guys know this already, right? Do we need to do this again? Just these parts we can do. So there's the dorsal root here. I already just did this stuff. So I think we're good on this. Just remember there's the medial branch. There's the lateral branch. 19 would be the dorsal ramus. This would be the ventral ramus. This is the gray ramus communicans. Let's see. This would be ligamentum flavum number 8. This is a beautiful ventral or epidural venous plexus. And then we have the thecal sac starts, the dura mater, arachnoid mater, and then this is interthecal area here, or subarachnoid spaces also. So we talked about that in lab. There's your practice. Just another view. We added in the disc in this one. So C5, remember the C4 disc would sit on the C5 vertebral body. The C4 vertebrae is not visualized in this structure. Let's see. I think that's all we need to say there. And this is pretty much review. So we have pedicles. The author could have drawn these a little more sturdy looking maybe. Those would be the pedicles. Articular pillar would be this piece right here. I mean, this is really the articular pillar. Really, it's the superior articular process, but going into the plane of the page. This piece is articular pillar, lamina, spinous process, transverse foramen. Now we can see these, remember the anterior and posterior tubercles, intertubercular lamellae. And this is the transverse foramen here. Right. Sometimes you can collectively call this the lamina and spinous process, and the lamina here. You can collectively call that the roof of the vertebral foramen, and the floor would be really the body and the disc. Kind of the sides would be the pedicle and articular pillars. We've talked about that before. Cervical intervertebral disc, very similar to everything we've looked at. Cervical is kind of in between. It's thicker than the thoracic, but it's thinner than the lumbar. Still has a nucleus and annulus fibrosis. It's designed like a steel belted radial tire where it has a center, and it is 80% water because of the proteoglycans and because of the gags that are produced by the cells there. It is corralled by lamellae, just like before. They are thicker anteriorly. The sagittal height of the disc is thicker anteriorly, which helps form the lordosis a little bit. Normally it's about 2/5 the height of the vertebral body. We've seen this before. Same thing applies to the cervical. Remember, the lamellae are sheets of collagen, type 1 collagen. They're very strong, and the collagen is arranged in these fibers running right here. So the collagen make up the lamellae, and they're they're orientated 65 degrees from a vertical line, but they alternate. So if I scraped this away and we looked at this layer right underneath it, those fibers will be running 65 degrees that way. Or you could call these positive 65 degrees, you could call these negative 65 degrees. So a very brilliant design, which makes the disc normally very strong. But we remember that these lamellae can be incomplete on the posterior lateral corners, and that allows the disc to herniate. The most common cause of radiating arm pain, which is semi-confined to a dermatome, like maybe down the C5 and C6 lateral part of the forearm and arm. If a patient comes in with burning like that, that's radicular pain because it stays pretty much in a dermatome. Very common cause, the most common cause of radicular pain is a cervical disc herniation. And the cervical herniation may or may not cause associated neck pain, headaches, scapula pain, upper back pain. Sometimes the annular tears are what that don't rip out of the back of the disc. You get a pressure buildup in the annulus and it stimulates sinovertebral nerves and you get a neck pain and not much arm pain. But once the disc rips completely through, the pressure is off the annulus and the neck pain may go away. Same with the lumbar spine. I see that all the time in my practice. The cervical discs can be injured from axial load injury. If you fall or you jump into a pool, hit your head in the bottom, which doesn't happen that often, but the twisting, the drivers of trucks who are constantly twisting their necks back and forth. Prolonged static flexion, someone looking at a keyboard, looking at a screen, and they don't have their head in a neutral position. They have their head flexed and they hold it in that position forever. That increases the chances for these disc herniations. And genetics, family history, also increases the chances for these herniations. Remember, disc herniations are not seen, despite what YouTube says. There's some crazy, actually, sadly, there's a spine surgeon on YouTube who claims he can see disc herniations on x-ray, which is absolutely insane. You cannot see disc herniations on x-ray. You have to see a herniation, or you have to see an MRI, order an MRI to see it, or you have to get a CT scan. A CT is not as good as an MRI, but you can see a shadow of it. Let's do a case study and see how things kind of work. Do you guys know your dermatomes yet? 40-year-old presents to your clinic with cervical spine stiffness, but strong. Let me start there again. 40-year-old female comes into your clinic, comes into your office. She has neck stiffness, but more pain radiating down from the trap all the way down the right lateral arm, forearm, and hand. A little bit of radiation down into the. I don't think that should be there because we just said above. I could take that out. Side 31. Neurological examination finds a right brachioradialis reflex. Do you guys know which nerve root? Typically, but not always, but typically supplies that. C6. As well as numbness in the lateral forearm and hand. What dermatome supplies that? Oh, look, C6. So, therefore, you've done a neurological examination. It's positive, so you can use the word radiculopathy. So, a working diagnosis means you have to confirm it by MRI, but a working, it's like a temporary diagnosis. It's a C6 radiculopathy. Right, there's the MRI. Oh, that's actually a normal MRI of a disc. Just to show you, this is a disc level cut. This is that same view we've been working with. You can see the uncinate processes here in white. You can see the disc here in black. You can see these are the neuroforamen right here. These are the vertebral arteries going through the transverse foramen here. This one's actually a little hypoplastic, isn't it? We'll talk about that in fifth quarter. But you can see the thecal sac with the white cerebrospinal fluid in it. And you can also see the spinal cord right here in black. Okay, so for disc herniations, we want to look at the back of the disc to see if anything's bugging out. And there's nothing bugging out. By the way, here's the facet joints that you guys adjust, and they look good. No arthritis there. Now let's see the patient. So again, our diagnosis was right C6 radiculopathy. So what disc herniation, here's the question, here's my question, the board question, and you have to know this for the rest of your chiropractic careers. If you find positive neurological exam in the C6 package here, neural package, what disc herniation would you expect causes a C6 radiculopathy? Well, to answer that question, you just need to remember what nerve root passes by the C6 nerve root. And that would be the C5 disc. So a C5 disc herniation gets the C6 nerve root. You want to see the C5 disc? Okay, not the greatest MRI. That's left. This is right over here. And now we look at the back, and no good, right? There's a big herniation right there. See that? And that's a pretty big one for the cervical spine. In fact, it's kind of smashed the spinal cord to the point you can't see the cerebral spinal fluid. Normal? No good. They have stenosis and short pedicles on top of this. No good. Okay, so diagnosis is confirmed. It's a moderate right C5 disc herniation, compressing the exiting C6 nerve root. So your diagnosis, I didn't put that in there, but your diagnosis of right C6 radiculopathy was confirmed. See how that works? Right? The patient actually ended up having a very successful ACDF, which is the gold standard with regard to cervical surgery. It's called the anterior cervical discectomy fusion. You can call it the Peyton Manning surgery. That's the one that saved his career. He went on to win a Super Bowl after all the teams dumped him. He monkeyed around with that silly laser discectomy and that stuff. Got a tried and true ACDF. Basically, they take out the disc and they can put in a bone graft here of artificial bone. The idea is this to fuse these two levels together into one block. The surgeons I work for prefer to take the bone out of the patient's hip. Patient's own bone has a great chance of actually growing. If you form a kind of a disc-shaped bony plug and stick it in there, it's got a really good chance of doing what bone does, what injured bleeding bone does, and that's forming more bone. And so you fuse, this is 5 and 6, fuse that together into one unit. And then you put a little plate on the front. That's like a cast to prevent over excessive motion while the fusion process occurs. This isn't the same patient. This is a 2-level ACDF in another patient of mine. All right, now we talked about Batman yesterday. So this is Batman. Everybody knows who Batman is. You know, he's got those little ears pointing up. So Batman's ears, those are the unsnate processes I showed you yesterday in lab, and they're very interesting. They form part of what's called the Luschka joints or the Uncovertebral joints. You have to know these AKAs. Uncovertebral joints, Luschka joints, joints of von Luschka, joints of Luschka. Here's joints of von Luschka. And they're unique to the cervical spine, and nowhere else in the spine has them. Mainly C3 to C7. Tallest are right between C4, 5, and 6. They're made of 2 parts, the uncovertebral joints. Batman's ears are the uncinate processes, aka uncus or unci for plural. I like uncinate processes better. And then there's a little facet on the inferior lateral corners of the bone above where these connect to. And they form a little joint there. It's a semi-true arterial joint. There's synovial fluid in there. So they can be a source of pain. And they look like Batman's ears. There's another picture of them. And I showed you yesterday how you can get bone spurs and they can shish kebab the nerve coming through there. Uncinate processes. More uncinate processes. These are a little degenerated, an older bone here. How's the joint classified? Some authors believe that they are true synovial diarthrodial joints, while others don't. So it's a little controversial. I don't think you'll see a question probably like that. Cramer doesn't even talk about it. There is a synovial membrane and synovial sites which make synovial fluid, so therefore they are. I say they're like a diarthrodial joint, but they do have a joint capsule and they do have synovial fluid. So, but Cramer is silent on the subject. Bogduke's silent as well. What do? So they give the spine. The cervical spine doesn't have any ribs, right? And it doesn't really have anything to support it when you're bending your head laterally. So when you're laterally flexing the spine, there's no help. And so these are thought to stabilize the cervical spine during lateral bending. And they could prevent lateral disc herniations. I showed some of you that yesterday, because they make a wall. The disc can't herniate through there very well. In fact, it can't herniate. There's no lateral disc herniations in the cervical spine. But as I said, they can develop osteophytes, bone spurs, and they can stab the exiting spinal nerve root there, and they can stab the vertebral artery. Right, so here's an overhead view. Here's the Batman's ears here, or Batman's, what are they, tufts, I guess. But here's some bone spurs that have grown out, and they're irritating this nerve root. And you can also get bone spurs growing on that superior articular process. If you get them growing on both structures, you're going to have not a happy patient. They're going to be dropping things. This nerve's not going to work very good. They're going to have to get surgery to decompress this. Okay, just to kind of blow up of the area. Right, and you can also see how there's a herniated disc where an annular tear has allowed the nuclear material to stick right out and irritate the motor nerve roots, and actually irritates both of the nerve roots once an inflammation starts. That's the most common cause of radicular pain. On this side we have another cause of radicular pain. We have uncinate process spurring, as well as superior articular process spurring, and it's irritated this nerve root. This patient's got bilateral radicular pain in the upper extremities. And if that's not bad enough, we can get ligamentum flavum thickening to compress the spinal cord here. That's where your proprioceptive tracts are. So they get really wobbly. They get myelopathic signs like a Babinski's test. Hoffman's test would be positive, and this is no good. This is called myelopathy. These are basically right here. You take this, if you learn this slide, this is everything you'll run into in your entire career right here. Serious conditions. Not the bread and butter little cervical sprain strain of the neck and things like that, which would probably get better without any treatment. You guys can speed the treatment. But the causes of chronic pain where they don't get better, these are the big three right here. Do a case, 58-year-old comes in. I remember, you know what, this guy was actually a chiropractor. I remember this case. 58-year-old comes in, severe radicular pain in the right arm with weakness, wrist extensor muscles. What root is that? What nerve supplies the extensors of the wrist? C6. Again. Brachioradialis reflex is gone on the right. C6 again. Hypoesthesia in the right lateral forearm and thumb. C6 again. So ended up getting a CT scan on this because of the bone spurs that we're seeing on X-ray. Here's his CT. What do you think? This is a coronal view. We haven't looked at these. This is a view, a slice going right through the middle of the vertebral bodies. Actually, it's toward the posterior. See Batman's ears? Uncinate process. See the disc here? Batman's ears. Now what happened? Holy smokes, look at that gigantic bone spur off the uncinate process of C6 and off the facet for the uncinate process here at C5. So they're crushing his right C6 nerve root here. So perfect fit. He was supposed to have surgery. He's still fighting it though. He didn't want to have the surgery. He needs it. Can't practice. Alright, everything I said. Alright, let's look at atlas and axis again. We've talked quite a bit about this. Here's the atlas, of course, and axis. What's this right here? What's peeking over the anterior arch? That's the dens behind there, or the odontoid process. So atlas is one of the two atypical. Atlas and axis are definitely weird, so they're atypical. Atlas is the widest of all the cervical vertebrae except for C7. It's the top of it. It articulates with the skull. It's the topmost bone. It's also C1. And there it is. Overhead view, quick. Overhead or underhead view? Or overhead or from underneath view? Quick, quick. It's underneath, right? If you think about axis, remember it's got those flat helicopter landing pads for articular process, supraarticular processes. So it has to meet there. Remember the top ones are concave, and the older you get, the more concave you get. But in general, just the general design of the atlas, we have four pieces. We have an anterior arch. We have, really it's an articular pillar, but they call it something different. They call it the lateral mass instead of the articular pillar. So you should call it, lateral mass is really, though honestly, it's more of a X-ray term. I still would call this the articular pillar. Specifically, that's the facet of the superior articular process, but the whole piece would be the articular pillar. And then we have a posterior arch. We have some stuff coming off. We have transverse processes. There's no spinous process on atlas. There's a posterior tubercle, and there's the anterior tubercle right there. That's it. Pretty simple. Transverse foramen. Double strutted. There's the anterior bar, anterior strut of the TP, posterior strut of the TP, intertubercular lamellae. The tubercles are not really not very visible. A to P view, or S to I view, or I to S view? Well, these are more concave looking. They're not flat landing pads, right? They're not these circular things. So this is definitely a S to I view. Right, let's go over the parts here. We've done this, I think, several times, but so these are the facets of the superior articular process. There are actually two of them. You could consider these separate facets if you wanted to. They can be quite anomalous. Colliculus atlantis, people were having trouble with that yesterday. It's that bump right there. It holds a very, very important ligament called the transverse ligament of Atlas, which runs right between there. The dens fits right in here. So the dens C1 and C2 are mainly held together by this really important ligament, transverse ligament of Atlas. This would be the lateral mass. I guess that could be called the lateral mass from here, or you could call it the articular pillar. This whole thing is the posterior arch, posterior tubercle, anterior arch, anterior tubercle. We got that weird posterior ponticle, right? We'll come to that. All right, that's all the parts. Another view from the front. So this you could call lateral mass. You could still call it articular pillar. They tend to call this the lateral mass, though, even though it's more of a radiographic term. But it is the articular pillar because it's a pillar of bone, right? And it has two facets, a superior articular facet, inferior articular facet, which we can't see. Yeah, lateral masses are just articular pillars. We shouldn't call them that, I say here. I guess maybe that's what Cramer must have said then. So maybe we better not call them the articular pillars. I'll have to check that. I don't see why you can't call them that, but they're made of superior and inferior articular facet, as we've seen. They're capped with an articular pad. We know that already. That will be the facet of the superior articular process. See, why do you call it the facet for the superior articular process if you can't call it the articular pillar? So I think that's wrong. I better check to see what Bogduke says. Bogduke doesn't do cervical, so doesn't have a book. Not a famous book anyway on that. You can see that transverse ligament of Atlas really nice there. These are the different fractures. You'll learn this as you go through the program. We don't have to worry about these right now, but Jefferson fractures, that's the one where you dive in the pool and you hit your head and it shatters your bone into pieces. Those are called Jefferson fractures. There is a pars interarticularis at the center of the articular pillar. See, I'm using articular pillars here. I think I'm going to take that out where it said that's 57, if I can remember. Now, these articulations, this is an important slide here. The lateral mass, or the atlas, does make some very important joints. And we always name the atlas first. So we have the atlanto-occipital joint and the atlanto-axial joint. So the one where the superior articular process, the facets of the superior articular process, connect with the occipital condyles is called the atlanto-occipital joint. The one where it connects with the axis superior articular process, it's called the atlanto-axial joint. The atlanto-occipital joints are, because of the shape of that superior articular process, the facet for superior articular process, it's called an ellipsoid joint. So that's a little bit strange. That's a really high yield board question. That's something you've got to remember. It's an ellipsoid joint classification. It's still diarthroidal, but specifically it's an ellipsoid joint. All right, there's just a A to P or P to A view where you can see the dens and the conda, or those would fit with the condyles of occiput. Right, you can also see on this cartoon, you can see atlantoaxial joint. There's the atlanto-occipital joint. Let's do a CT scan. Look at that nice view of dens, perfect view of the dens, and you can clearly see atlantoaxial joint, atlanto-occipital joint. Okay. And you can see this is occiput right there, that connection. Transverse processes, they're semi-double strutted in some, we saw one that was pretty well double strutted, but not all of them are. Sometimes they're faintly double strutted, but they lose that C5 look where they have really individual double struts. They project laterally. They're very anomalous too, I can add, these transverse processes. I think I've talked about that before. When you get in the lab, you might be able to feel one on one side and you can't feel the other one because they're super anomalous. They have a transverse process. V3 of the vertebral artery goes through there. You can see them right here. Remember V3 is born right when it comes out of C2. Transverse foramen, that would be V3. It goes through that hole, goes through here. Then it does a crazy 90, sometimes 120 degree bend, and it goes in the groove for the vertebral artery, which is right there. It's a nice view of that groove for the vertebral artery. Remember we said sometimes that posterior atlanto-occipital membrane grows over the top and it calcifies over the top and it forms a piece of bone like it did over here. We said that's a posterior ponticle. That's an arcuate foramen right there. Do I have slides? I think I have slides. Either that or next time. It can be the transverse processes can be very asymmetrical, one long, one short. It has an anterior and posterior tubercle, but they're not coming off the anterior and posterior arch respectively. We've looked at that several times. Now, unlike typical vertebrae like C5, 6, 7, C4, they don't have uncovertebral joints. So there's no Luschka joints between C1 and C2 and C1 and the occiput. So that's another good, easy board question. No uncovertebral joints, no unsnate processes. Okay, there's just another view. Look at the difference of these transverse processes. They look completely asymmetrical. This one looks like a kind of an ankle shoe type look. This one kind of looks like that a little bit, but you can tell they're quite different. This one sticks out quite a bit further than that one. Superior articular processes, we've talked about that already. Sometimes the facets, well, here they are again. As I've said a couple times already, the concavity, right? This is a concavity. This is a younger one here. But this gets deeper with age, and you can use that to get an idea of how old the person is. And contains an articular facet. Don't forget to say facet of the superior articular process. We know that. And then I've already said this. Is this the I to S view or SI view? This is an IS view, right? Because these are flat. They would connect with C2. Let's see. They can be grossly asymmetric too. All of these articular processes, 37% of superior articular processes, of facets of superior articular processes, actually have 2 or 3, even 4 different facets. So they can have multiple facets. In this one, technically, you could say there's one here. There's one here. Some people might even consider this its own facet. We'd have to see, of course, the living tissue to see. But they can have multiple facets. Anterior arch, we've talked about it, right? It's just that anterior arch, and it has that bump on it called the anterior tubercle. Who cares about the anterior tubercle? Well, there's some things that connect to that anterior tubercle. The anterior longitudinal ligament and the superior oblique fibers of longissimus colli. It looks like the recording cut out. It's hard to tell what happened. Posteriorly, it contains a facet as well, that tubercle. Oh no, we're still talking about the anterior arch. So there is a facet where it connects with the odontoid process. So that's just called the facet for the dens. This is actually important because it makes up a space called the ADI space. Very important space, Atlantodens Interval. The odontoid has a facet for the articulation of the facet for the dens. That's called the facet for the anterior arch. So let's look what I'm talking about. So that is a facet. Remember, the dens would go right here. This is a P to A view of atlas. There's the groove again for the vertebral arteries, but there's the facet for the dens, which would articulate with the dens. The dens has a facet called the facet for the anterior arch, and those two connect together. They have a capsule. It's a true diarthroidal joint. See, there's the facet for the anterior arch of atlas. Nice picture of the dens. We would have our facet for the alar ligaments would be right here and here. This ADI space is super important. It should always be fairly snug. This is the ADI stands for Atlantodens Interval. Look at all the stars. You gotta know the ADI space. Should never, ever be bigger than 3 millimeters. That's it. Especially if they've had an accident. Someone who's had trauma, you should take a cervical series, the A to P open mouth. But you see it on the lateral. It should never be bigger than 3 millimeters. If it's bigger than 3 millimeters, you should not do grade 5 manipulation. You should not crack them, because they may be unstable and you could kill them. Right? You'll learn some orthopedic tests to confirm that. But this is the ADI space right here. You'll always see a little gap here on X-ray. CT you can see it really nice, but it shouldn't be a big gap. Nice colliculus, Atlantis there. Right, so there it is, about 1 or 2. They're usually 1 to 2 millimeters in width. Right, posterior arch, we've talked about that already. Forms about 2/3 of the ring of atlas. Has that bump, right? There's the posterior tubercle of the posterior arch. Who cares about that thing? It's an attachment site for ligamentum nuchae, which we'll look at next week. It also has a muscle connected to it, the rectus capitis posterior minor muscle, which we'll look at. I think, have we talked about that? Suboccipital triangle. The lower border of the the posterior arch has 2 different sets of ligaments attached to it. So the lower border has ligamentum flavum. That's the last of ligamentum flavum. And the upper border has, we've been talking about this, posterior atlanto-occipital membrane. So here's the C1, here's the inferior border, and that's the last ligamentum flavum. Last ligamentum flavum is between C2 and C1. Right, there's atlas. That's it. No more ligamentum flavum. There's no ligamentum flavum between atlas and occiput. Instead, there's a thinner, broader, more membrane. It's not thick enough to be really called a ligament. And that's the posterior atlanto-occipital membrane. And we said V3 goes right through there, does a bend, and then penetrates into that. And we said sometimes this can calcify. And that forms a posterior ponticle when that calcifies. Groove for the vertebral artery. We've talked about that. That transmits the vertebral artery, V3 of the vertebral artery. The vertebral vein and the suboccipital nerve is important. That's the headache nerve. We'll talk more about that next week as well. But again, there's that groove for the vertebral artery right there. And colliculus atlantis, we've already talked about that. That's where the transverse ligament of atlas connects to, and super important for the ADI space stability. And we've talked about it. There it is again. Okay, and remember there's a transverse ligament. The dens would be right in between, right here. I don't know how to draw that underneath that, but super important for stability of C1, C2. All right, so I will get this rendered down. See y'all later.